Welcome to this video. Dr. Saeed Kazmi here, and today we are going to talk about the chest trauma in children. Chest trauma in children is more common in the first decade of life. It is considered to be rare, but it can cause, if it does happen, it can cause high morbidity and sometimes can even lead to high mortality if the mechanism is very significant. Now, in children, experience has told us that it's mostly caused by high energy blunt blows, like for example, a child who suffers a road traffic collision. It can also occur in scuffles when adolescents, they're fighting one another and they get like punches or kicks to the chest. It can also occur in sports injuries, like kids colliding with one another, or getting a high energy blow to their chest, like for example a cricket ball or a baseball hitting their chest. So these are some of the common mechanisms by which children can suffer blunt chest trauma. Now, rarely it can also be what we call as penetrating chest trauma. Now, penetrating chest trauma carries more high mortality. It's usually caused by knife injuries or can occur because of ballistic injuries as well, like gunshot injuries. And it can happen accidentally. It can happen because of homicidal attempts, sometimes even suicidal attempts in certain societies. Now, usually chest trauma in kids, it can be an isolated injury. For example, a sports injury where a child has been hit on the chest, or let's say two teenagers who are fighting one another and they get blows, they exchange blows, and one of them get hit on the chest. But high energy trauma is usually associated with extrathoracic injuries as well. Like for example, somebody who is involved in a high-speed road traffic collision, so they can suffer chest trauma, but at the same time, because the mechanism is such that it would not only be the chest trauma, it would be abdominal trauma as well, it could be head injuries as well. So it's usually what we call as a polytrauma or a multi-trauma, in which chest is just one part of the body that is injured, but there are other parts which are injured as well. And as I told you, that usually in low impact injuries, nothing happens because kids chest walls, they are quite blind. But obviously, if there is a high energy blunt trauma, then it can lead to significant morbidity and in certain cases, a high mortality as well. Now moving on and talking some of the common types of injuries which are encountered in chest trauma. Now, number one are the low impact injuries. Now, low impact injuries, like for example, a child falling and hitting his chest, or a low impact blow to the chest, or let's say something falling on the chest from a small height, they mostly lead to soft tissue injuries. So soft tissue injury means that the muscles of the chest wall might be sore. There might be a little bit of superficial bruising that hurts, but there is no damage to the internal organs of the thorax. In other words, there is no damage to the lungs, there is no damage to the heart, there is no damage to the mediastinal structures. While the other types of injuries are what we call as high impact injuries. High impact injuries are road traffic accidents or a very high ballistic impact to the chest wall. For example, being hit by a very fast cricket ball, or hit by a very high speed baseball, or getting multiple significant high impact blows to the chest. So they can lead to significant morbidity. They can injure the structures inside the thorax. So it can lead to lung injury, it can lead to cardiac injury, it can lead to mediastinal injuries. So some of the common clinical entities that happen because of significant high impact injuries are, number one, hemothorax. Hemothorax means bleeding inside the chest cavity, and it usually occurs when there is pulmonary contusion. So if the lung tissue is damaged, the lung tissue is torn, so that would lead to bleeding, because lungs are a very vascular structure, because obviously they have to use the blood in gaseous exchange. So tears inside the lung would lead to bleeding, and this bleeding would accumulate in the closed cavity of the thorax, and that would lead to what we call as hemothorax. So hemothorax means bleeding inside the chest cavity, and this bleeding can be within the pleural space, it can be within the lung tissue itself, The other type of injury is pneumothorax. Pneumothorax means air in the pleural space. And again, it usually happens when there is significant injury to the airway structures. For example, the bronchi, they are fractured or ruptured, or any part of the airways, they are ruptured. So what would happen is that the air would leak from these air spaces and would accumulate in the dead space of the pleural cavity, and that would lead to what we call as pneumothorax. Now, pneumothorax can be again a simple pneumothorax or a tension pneumothorax. A simple pneumothorax means that the air accumulates within the pleural space, but it does not lead to significant circulatory or cardiocirculatory or cardiorespiratory compromise. When this pneumothorax is such that air builds up within the pleural space and it cannot escape anywhere, then it would cause the shifting of the mediastinal structures to the opposite side. So it would lead to pressure on the cardiac tissue. It would lead to pressure on the adjacent lungs. So it would lead to cardiorespiratory compromise. So the child can develop shock, the child can develop hypotension, the child would have engorged veins. This is what we call as tension pneumothorax, and that is a genuine emergency. The third thing is cardiac tamponade. Cardiac tamponade means when there is injury to the cardiac muscle leading to the bleeding, and that bleeding or the blood accumulates within the pericardial space. So that's what we call as cardiac tamponade, and it would cause pressure effects on the contractility of the heart. So the heart cardiac output would be decreased because of this pressure of the blood on the heart within this closed pericardial sac. High impact injuries can also lead to bone injuries. So bone injuries, mostly here we are not talking about the spine, the thoracic spine, something here. By bone injuries we mean significant rib fractures. So ribs can fracture, and the ribs are like sort of, they are in a C shape. So usually if you compress, it's usually the angles where they can break. So most of the fractures would be at the angles, the rib fractures. And last but not least, mediastinal injuries. So mediastinal structures are esophagus. Mediastinal structure is your bronchi. So they can you can have esophageal rupture. Obviously, that would lead to severe mediastinitis, and air can accumulate within the mediastinum, which we call as pneumomediastinum, if the major bronchi or the main stem, the left or the right bronchi, they are ruptured because of the blunt trauma to the chest. Moving on to the clinical features. Now, the clinical features, it's important that you understand the mechanism of the injury. Most of the times when you are confronted with a significant high impact chest trauma, the paramedics or those people who have witnessed the injury, they would tell you about the mechanism of the injury. So mechanism of injury itself tells a lot. So you can anticipate, like somebody who was involved in a high-speed traffic accident. So you can understand that he can have pulmonary contusion, he can have hemothorax, he can have pneumothorax, he can have cardiac tamponade. But somebody who just had like a small blow to the chest, that probably nothing would have happened. Other clinical features usually in such cases are chest pain. Obviously, chest pain can happen in low impact chest trauma. It can happen in high impact chest trauma as well. And there might be signs of external bruising depending on the impact. You also might find that the person who has suffered a high impact chest trauma might be suffering from difficulty in breathing. He might present with features of shock, which means he might be tachycardic, he might be tachypneic, and he might be having hypotension. Sometimes you might see a flail chest. A flail chest is a segment of the chest which is moving on its own. So it's not following the breathing pattern of the rest of the chest wall. So we call it as paradoxical chest movements. So usually when a child is breathing, so when he breathes in, the chest comes out, and while the chest wall comes out, the flail segment would dip in. And usually when you see a flail chest segment, it simply means that there are rib fractures at that spot. So usually there are multiple rib fractures at that. So flail chest is equivalent to rib fractures within that area. You might see engorged neck vein. So usually when there are pressure effects inside the thorax, whether it is in the form of cardiac tamponade, whether it's in the form of tension pneumothorax, or whether it's in the form of massive hemothorax, that would lead to engorged neck veins. So you would see, like, bulging neck veins. Then some of the things are based on your examination. So if you do the chest percussion, again, apart from inspection, the important thing to do is chest percussion and auscultation. So percussion, when you are percussing the lung fields, you might find dull notes or you might find hyper-resonant notes. Remember, if you find dull notes, the dull note simply means that there is fluid, some form of fluids, and usually that is blood in this particular case. So that simply means that there's a accumulation of blood, hemothorax. But if there are hyper-resonant notes, then obviously it means a lot of air under that particular segment where you are doing the percussion, and it simply means pneumothorax. Similarly, when you are doing chest auscultation and you're putting a stethoscope on different parts of the chest, you are actually hearing for the breath sounds and for the heart sounds. So if there are absent breath sounds simply means that that part of the lung is not working. So there might be a pneumothorax or there might be hemothorax on that particular area. And if you hear that the heart sounds are muffled, you can't hear them clearly, they are very difficult to pick up, then probably it means that there is sort of a fluid around the heart. In other words, you are looking at a cardiac tamponade. So remember these things. The dull percussion notes in chest trauma is equal to hemothorax. Hyperresonant notes mean pneumothorax. Similarly, absent breath sounds mean either hemothorax or either pneumothorax. It could be any of those things. Again, then on examination, further percussion can tell you whether it's more going in favor of hemothorax or more going in favor of pneumothorax. Sometimes both can coexist as well. So let, for example, significant trauma in the lower part of the chest, you are auscultating and you find dull, and at the top you find hyperresonant note. So, well, you can say that probably there is a sort of a hemothorax in the lower part and a pneumothorax in the upper part. So remember, it's not necessarily that you will have only one type of finding. Depending on the injury, you can have sort of a mix of different findings. And remember that in these types of injuries, usually you find everything. So you can, in the same patient, you can find a pneumothorax, you can find a hemothorax, and you can find a cardiac tamponade, depending on the seriousness of the injury. So this is what you find on your examination. This is how you do your examination. These are some of the clinical features that you might see in a case of chest trauma. Moving on, so how do we manage these cases? So here we are talking about the management of the pediatric chest trauma. So number one, again, if it is an insignificant chest trauma, then obviously you would start by looking at the vitals, and you would do your examination, and probably if you find nothing, all they need is reassurance and probably painkillers. But here, when we talk about chest trauma, we are focusing on significant chest trauma. So if there is a significant chest trauma and you're working in an emergency department setting, the first thing is to place a trauma call. So at least you've got help when the patient arrives. You've got surgeons beside you, you've got the anesthetist beside you, and you've got like helping hands with you. Now, irrespective of the mechanism, whether the person has been injured in a road traffic accident or whether he fell from a rooftop, again, you always start with your ABC. So obviously airways take the priority in that case. Hopefully with these things, if there has been no injury to the head and neck region, most probably you're going to find clear airways, and then you move on to the B part. Obviously with just the B and the C are more important. So you do a quick inspection of the chest. So you look for any external bruising. Obviously if there are massive bruising, massive deformity, then you know that there will be definitely rib fractures, there will be pulmonary contusion, and probably you are looking at hemothorax as well as pneumothorax. You also look for any penetration, like people who have been stabbed in the chest. Then if there's a stab injury, that is usually carries a very high mortality. And if somebody has got like a knife in the chest, so you are looking at probably a pneumothorax, you're also looking at a hemothorax, you're probably looking at a pulmonary contusion, and probably you're also looking at cardiac tamponade. So you probably would have all these findings in the same patient. Similarly, if you find a flail chest segment, so you know that you are looking at rib fractures, there are multiple rib fractures. Then you go on, you look at you record the vitals, and then you move on with your chest percussion and auscultation. So I told you earlier, if you find hyperresonant notes on percussion, you are looking at pneumothorax on that particular site. If they are dull, you're probably looking at hemothorax or pulmonary contusion. Similarly, in auscultation, if you find that there are absent breath sounds, you're either looking at hemothorax, you're either looking at pneumothorax, or there might be a massive pulmonary contusion beneath that area. And if you are hearing muffled heart sound, then probably you are dealing with a cardiac tamponade. So an examination can give you a lot of anticipated underlying conditions, which even without a chest x-ray or a lung ultrasound, you know that what you are dealing with, and you can simply then do the rest of the things to confirm your findings and then manage them accordingly. So how do we manage them? So we always start with giving them 100% oxygen, and we also start by giving them painkiller. These are the things that you would do irrespective of what are you looking at. But obviously you need to give painkillers because those people who have got significant chest trauma, they would be in a lot of pain, they would be in a lot of anxiety. So you give them painkillers, so at least that would help in anxiety as well. That would decrease the pain as well. Similarly, you give 100% oxygen to help in the breathing process. Now, if you find features of tension pneumothorax, for example, you find hyperresonant nodes, engorged veins, the person is having features of shock, then you don't wait for the chest x-ray to confirm pneumothorax. It simply means tension pneumothorax. A tension pneumothorax is a pneumothorax with features of shock. So there is engorged veins, there would be hypotension, there would be tachycardia and tachypnea. So in that particular case, what you can do is you can take size 20 cannula, and you can do a needle thoracostomy. So needle thoracostomy is done on the affected side in the second intercostal space in the mid-clavicular line. So you can just do it. In emergency procedure, hardly take a few seconds, and as soon as you press it, and the air would escape. So there will be hissing sounds, and the air would escape. And obviously that would relieve the tension. That doesn't solve the problem, because in all these cases later on you have to complete the procedure by putting up the chest drain. A chest drain, the patient can wait for a few more minutes, even hours to for the chest drain to be placed. At least you can save his life by doing a needle thoracostomy. So needle thoracostomy in kids, we can use the size 20 cannula, and that is the second intercostal space in the mid-clavicular line. At the same time, if you hear muffled heart sound, so you know that you are dealing with cardiac tamponade, that's another deadly condition. You need an immediate bedside echo to confirm your findings. And obviously, if you find that there is cardiac tamponade, then pericardiocentesis needs to be done on the bedside. Or if there are signs of penetrating injury or something, these kids needs to be rushed to the theater, where open thoracostomy and obviously closure of the primary defect in the cardiac muscle, that has to be done. So the repair has to be done. Once you have done your emergency procedures, then you can confirm your finding with the chest x-ray plus minus chest ultrasound. So depending, you can do a bedside chest x-ray, or if you have got good hands on the practice with the chest ultrasound, you can use the chest ultrasound to confirm or refute your findings as well. So you can look for echo, you can look for pneumothorax, you can look for hemothorax with a chest ultrasound. So you can do the EFAST scan. Now, if you look at these three x-rays, so if you look at the bottom x-ray on the left one, so you can see that on the left side here, if you see, this one is more darker as compared to the other side. At the same time, you can see that there is absence of lung markings. So absence of lung markings is one of the most significant features of pneumothorax. So a pneumothorax would present with dark lung fields on that particular side, but those dark lung fields would have absence of lung markings. So absence of lung markings mean that there is air within the pleural space at that particular side, and you can see that this is a tension pneumothorax because there is air in the pleural space, and this air has pushed the mediastinal structure to the opposite side. So you can see the trachea has been shifted to the right side, and you can see that the heart and the lungs, they have been shifted to the right side of the chest. So this by definition is a what we call as tension and pneumothorax. Now looking at the middle x-ray, chest x-ray over here, Now, this is a supine X-ray. Now, keep it in mind that normally, ideally, erect X-rays should be done, but these kids who have got significant chest trauma, it would be very difficult to get their X-rays in an erect position. So, most of the time, the bedside X-rays are done, chest X-rays are done, and they are done in supine view. So, in supine view, you can't look at the fluid levels which you can see in the erect X-ray. So, if somebody has got hemothorax, that means blood in the chest cavity, then erect can show you a fluid level by which you can know that that is basically hemothorax on that side. But when the patient is supine, that you will not be able to see those fluid levels. So what you would see is that that particular side where there would be bleeding, that would be more opaque. So there will be a generalized haziness of that particular part of the chest as compared to the other side. For example, if you look at this chest X-ray in the middle, so you can see that the right side of the chest has got more haziness as compared to the left side. So you can see it seems like the heart is shifted to the left side of the chest. So there is a sort of a mediastinal shift towards the left side. And you can see there are a lot of whitish haziness, going in different directions. Because this patient is supine, so you can't see a sort of a fluid level. This is because there is blood within the right side of the chest, and this is a case of hemothorax. Obviously, if you delve deep into and you magnify this image, you will see that there are multiple rib fractures on this side as well. But I should also emphasize that normally chest X-rays are not done to detect rib fractures. Rib fractures, usually the most sensitive test is a CT scan. But other than that, it's mostly a clinical diagnosis. So unless and until it is not associated with significant hemothorax or pneumothorax, rib fractures, they are not treated operatively. And obviously, all you can do for those rib fractures are to prescribe painkillers for some time. So the learning point here is that hemothorax on a chest X-ray, especially in supine position, would actually appear as haziness of that lung field as compared to the other side. But if you do an erect X-ray, then obviously, if it is significant hemothorax, you might see the fluid level. If it is just a small hemothorax, that it might lead to blunting of the costophrenic angle only in the erect X-ray. Obviously, you can't see any blunting of the costophrenic angles on the supine X-ray. Supine X-ray are just going to show you haziness. So if there is a haziness, that is hemothorax. And hemothorax also means that there will be pulmonary contusion, underlying pulmonary contusion, because where the blood would come? The blood would come when the lung, there is tear in the lung tissue, and obviously the blood vessels, they rupture, and that leads to bleeding. So hemothorax is synonymous with pulmonary contusion, and that would lead to haziness on that part of the chest when you do a supine chest X-ray. Hope you remember these things. Now, if you look at the third X-ray, now here you can see that the cardiac shadow is very much enlarged, a globular or a flask-shaped cardiac shadow. And obviously, this would be associated with muffled heart sounds as well. So muffled heart sounds, and the best thing is to do an echo. But let's say if the echo is not there, you can confirm it with the chest X-ray if it is a significant cardiac tamponade. So that would lead to increase in the cardiac shadow, and that simply means that that child has got cardiac tamponade, and that means that you have to do emergency pericardiocentesis. So that is how you detect hemothorax, pneumothorax, pulmonary contusion, and cardiac tamponade on a chest X-ray, and it's very simple to detect. So if you know what are the findings on your percussion and auscultation, and then you combine it with your X-ray findings, you can straight away, you can pinpoint the underlying trauma to the organs, whether it is the pulmonary contusion, whether it's hemothorax, whether it's pneumothorax, or whether it's cardiac tamponade. Okay, now let's consolidate this knowledge by a few clinical cases. So the first case is that it's 2-month-old baby is brought by his worried parents because their domestic cat jumped on the chest of the baby. So the baby was lying on the floor and the cat jumped on the chest. Now you do the examination. He is fine. There is no evidence of chest bruising and his vitals are normal. So you do the chest examination. So breath sounds are equal. This is bilateral equal air entry. You can't hear any absent breath sounds. Heart sounds are absolutely normal. So what would you do in this particular case? The parents are also very anxious. So obviously in this case, you need to give them a reassurance and tell them that the mechanism is low impact and nothing has happened, and obviously they don't need to worry about these types of injuries. Case number 2, a 16-year-old has been punched on the right side of the chest. So let's say he was involved in a brawl and he was punched on the right side. Now he's complaining of pain in the chest and he says this pain is aggravated by breathing. So when he takes a deep breath, he holds it because it hurts on that particular side. So you do the examination, there's no rib crepitus, so you don't feel for any rib fractures. The chest is clear to auscultation. His mother is worried and is requesting a chest x-ray, and she says that she wants chest x-ray because she's worried that the boy might have a rib fracture. So what would you do? Now in this particular case, you will not do chest x-ray. You will not do chest x-ray. Why? Because chest x-ray has got very low sensitivity in picking up rib fractures. And the other thing, even if rib fractures are there, it does not change the management. Isolated rib fractures where there is no damage to the underlying lungs or underlying structures, which obviously he has got clear lung fields. You can't hear any dull breath sounds or muffled cardiac sounds. So all he needs is painkillers. So you would give him painkillers because painkillers, otherwise if these people are not breathing properly and they hold their breath because of pain, then they can end up in chest infections later on. So you need to give them liberal amount of painkillers so that the pain is under control and they don't develop any later complication like a chest infection. So you will not do any chest x-ray and you need to prescribe painkillers to this particular child. Now, the case number 3, a 16-year-old boy is involved in road traffic collision. He's brought by paramedics as a priority call. Now, on arrival, you see he's in severe chest pain. He's anxious, he's restless, and he's perspiring. So what does that mean? Severe chest pain, obviously, might have some rib fractures. He's anxious, restless, and perspiring. This probably means that he is developing shock. His neck veins seem distended, so probably there is a lot of pressure inside his chest. You examine him, his chest is clear to auscultation, but the heart sounds are barely audible. So heart sounds are muffled. What does that mean? It simply means that he has developed cardiac tamponade. So he has got cardiac tamponade, and cardiac tamponade is putting up pressure on the heart. The heart is not able to pump the blood, so the cardiac output is reduced. The backward pressures are increased. That leads to engorgement of the neck veins, and because of the low cardiac output, he is developing shock. So he would be having tachycardia, and he's having the other manifestations of shock, which is restlessness, anxiety, perspiration. So obviously you would do, next step would be a bedside echo, and that would confirm. And if that is confirmed, you need to do an emergency pericardiocentesis. So these are the few clinical cases which have consolidated your knowledge on chest trauma in kids. It's not a difficult subject. All you need is to know that there are just a few things that can be damaged. So it could be either a pulmonary contusion, which is tear in the lung tissue. It can be pneumothorax, it can be hemothorax, and it could be cardiac tamponade. These are the only significant injuries that you cannot afford to miss. And it's very easy to pick them if you combine your clinical knowledge with the proper examination skills, and obviously if you can read the x-rays, which are very easy, especially in case of pneumothorax and cardiac tamponade, so you can easily pinpoint the damage to the underlying structures, and then you can manage them accordingly. So I hope you have understood this lecture on chest trauma in kids. If you still have got any questions, you can put it down in the comment section below. I'll get back to you. And if you haven't subscribed to my channel, please do subscribe and share my videos with your friends, and have a very good day. Bye bye.